So, good morning, everybody. I'm happy to present today's resident lecture on Echinococcosis. Will be held by Daniel Gero, our current resident in the HPB and Transplant Center. Daniel Gero joined our department in 2017 and just recently finished successfully his PhD in clinical science. And I welcome him, and it's your stage.
Good morning. Welcome to my lecture on echinococcosis. As a wake-up slide, I would like to introduce my dog, Pipoca, who looks very healthy and innocent, but she may be a risk to our health. And in this presentation, I will explain why. We're going to talk about biological properties of echinococcosis, epidemiology of echinococcosis, diagnosis, workup and staging, therapeutical options, special focus on surgical techniques, and some future challenges. Echinococcus genus belongs to the class of Cestoda, which are commonly called as flatworms. Two most important pathogens are the Echinococcus granulosis, which leads to the cystic echinococcosis, and the Echinococcus multilocularis, which leads to alveolar echinococcosis. More recently, it has been described that there are newer Echinococcus species, such as the Echinococcus vogeli and oligartrus, which can be responsible for polycystic echinococcosis, or the Echinococcus felidis and Schicicus, which haven't yet been related to a human pathology. So I would like to emphasize up front that there is a name alert. Cystic echinococcosis and alveolar echinococcosis are two very different disease entities, and during this presentation I will walk you through stage by stage on both diseases in parallel. So on this figure you can see the life cycle of cystic echinococcosis, which is called the zoonosis because it needs a mammalian host to mature its life cycle. Here the hosts are sheep and dog, and humans can become accidental intermediary hosts by fecal-oral transmission of the eggs of the parasite. The clinical course of cystic echinococcosis is often asymptomatic for months and years until the cysts grow large enough, and at that moment it can lead to following symptoms: discomfort, nausea, vomiting, and other symptoms depending on the location of cyst. So my first question to the resident will be, which organs are most frequently affected by cystic echinococcosis?
I would say mainly the liver, or then the lungs, and sometimes also other organs like kidney, for example, or spleen.
Yeah, that's correct. So the main affected organs are the liver and lungs. Sometimes the spleen, kidneys, heart, bone, and even the central nervous system can be affected. If a cyst ruptures by trauma, it can lead to mild to severe anaphylactic reactions or even to death. The life cycle of alveolar echinococcosis is also similar. It's a zoonosis. It needs intermediary hosts. Here the host is the rat fox. And again, humans can become accidental intermediary hosts by fecal-oral transmission. The clinical course of alveolar echinococcosis is more comparable to a tumor. It's a parasitic tumor of the liver, which spreads to the neighboring organs. This echinococcosis does not fully mature into cyst. It develops small vesicles that invade and destroy tissues. Symptoms are discomfort or pain, but can lead also to weight loss, malaise, liver failure, cholangitis, and death because of the spread into nearby tissues. The mortality rate is reported to be quite high, between 50 and 75%, because most affected people live in remote locations and have poor health care. This brings us to the epidemiology of echinococcosis. On this map, you can see the geoepidemiology of cystic echinococcosis. We see that the Northern American continent is not really affected. On the contrary, there are some endemic areas in Southern America, Africa, Middle East, or the Siberian Peninsula. On this map, you can see the increase in the red fox population in Europe in the last 15 years. Also in Switzerland and also in Zurich. Last summer, the media reported presence of red fox in this building where a sleeping patient was attacked. A Swiss publication has showed a correlation between the increasing number of fox population and the number of reported human alveolar echinococcosis. The yearly incidence is somewhere between 10 and 25 cases with a seroprevalence of 0.2%. Now I would like to talk about diagnostic workup and staging. When we have the suspicion of echinococcosis, we can perform a blood test. Here, the leukocytes will be most frequently normal. We may find eventually a cholestasis or an eosinophilia, sometimes elevated immunoglobulin A. But the most sensible and specific test to perform is the Echinococcus serology by ELISA or Western blot. Then we can move on to an ultrasound. For cystic echinococcosis, we may identify cystic lesions with a wall and membranes, which are very sensitive and specific to this disease. Whereas for alveolar echinococcosis, we can find small cysts, signs of necrosis or calcification. It is recommended to perform a CT or an MRI. For cystic echinococcosis, this will identify septation, calcification, and for alveolar echinococcosis, necrotic caves or calcification. We can perform complementary imaging, for example, FDG PET, which has been reported to be helpful in differentiating alveolar echinococcosis from cystic echinococcosis because there is a lack of perilesional increased FDG uptake in cystic echinococcosis. We can also proceed to ERCP to identify if there is a biliary tree involvement and to place stents if necessary. This image shows the World Health Organization classification of hydatid cysts. There are 5 stages, and this stage may be interesting to decide the treatment. In the stage number 1, we can find an anechogenic cyst with fine echoes inside representing hydatid sand. In stage 2, there are cysts with multiple septums. In the stage 3A, we find one uniloculated cyst with decollated so-called proligare membrane, which radiologists with high imagination have named the water lily sign after this plant. This is this membrane which we can find inside the cyst. In stage 3B, we find daughter vesicles, and stage 4 and 5 are the so-called inactive cysts because we find calcifications and a mixed content of hypo and hypoechogenic cysts. So my second question to the resident would be, what is the PNM classification of alveolar echinococcosis, and what are the common features between alveolar echinococcosis and the malignancy? Please.
Parasite, and I think N is for the perihepatic involvement and M for the metastasis.
Yeah, that's correct. So it's an analogy to the TNM classification where P refers to the local parasitic involvement in the liver, N is the perihepatic involvement, and M the distant lesions, which are quite rare. The common feature between alveolar echinococcosis and the malignancy is the destruction of local tissues and invasion of other organs. Now I would like to talk about therapy. The currently prevailing recommendation of the World Health Organization has been published 10 years ago. It's a fruit of an expert consensus meeting where our institution had the honor to delegate a member, Professor Mühlhaupt, who is here with us today. According to this expert consensus, I prepared a table on an overview of the treatment. For both cystic and alveolar echinococcosis, when the lesions are small, it is justified to begin with a medical therapy, which will be antihelminthics, albendazole or mebendazole, which have inhibitory effect on tubulin polymerization, which result in the loss of cytoplasmatic microtubules. Surgical therapy is indicated for both diseases. For cystic echinococcosis, our preferred approach would be a pericystectomy, but I would like to also mention the existence of endocystectomy, sometimes the need of a pericystal hepatic resection, or as a last resort, a liver transplantation. In case of alveolar echinococcosis, the surgical approaches are liver resection. Here we have to aim for an R0 resection or a liver transplantation. In some endemic areas where access to surgery is limited, there are some interventional percutaneous approaches that are used quite frequently, which have different abbreviations like PER, MOCAT, or PVAC. These refer to punction, aspiration, instillation, reaspiration, or modified catheterization technique. The watch and wait approach may be sometimes justified for cystic echinococcosis, but it's not recommended for alveolar echinococcosis. These cases where we can do watch and wait belong to this stage 4 and 5 cystic echinococcosis, where we face to inactive cyst. For all other type of cystic echinococcosis lesions, surgery is justified. I would like to mention that the interventional radiologic approach may have also some inherent complication. On this picture, you can see signs of hemophilia after the application of puncture, aspiration, instillation, reaspiration. Here we inject a cholecidal agent for 10-15 minutes, which can be either a hypertonic saline solution or a 95% ethanol solution. Albendazole, the most frequently used drug, has many adverse effects. Frequently reported adverse effects are headache or abnormal liver function tests. Patients often complain of abdominal pain, nausea, vomiting, dizziness, fever. And I would like to mention also the price of this drug, which is around 15 francs per day. But when we prescribe it for 2 years, it can reach a price tag above 10,000 francs. Now I'd like to focus on the surgical techniques. I would like to ask first, what are the frequent indications for surgery for cystic echinococcosis?
I guess maybe the cyst on the liver surface with risk of rupture, or maybe a ruptured cyst, or cystobiliary fistulas, or maybe compression of neighbor organs.
Yeah, that's correct. So these are frequent indications of surgery. On this figure, I would like to show the difference between endocystectomy and pericystectomy. The idea of pericystectomy is to remove the cyst in totality without opening it. When we perform endocystectomy, we leave the posterior wall of the cyst on the surface of the liver. This wall is composed of an adventitial layer, a laminated layer, a germinal layer, which belong to the echinococcal cyst. These intraoperative pictures show the steps of an endocystectomy, which starts with the identification of the cyst by intraoperative ultrasound. And then we prepare by drapes the field to avoid the contamination of other organs. Then we can proceed to the aspiration of the cyst, the extraction of membranes. And then at the end of the procedure, we sterilize the cyst with either hypertonic saline or ethanol solution. And at the end, we can plug in some omentum in the cystic cavity. Our preferred approach here in the USZ would be a pericystectomy, the removal in totality of the cystic lesion without opening it, leaving a resection surface like after non-anatomic liver resection. Now I would like to talk about the treatment of alveolar echinococcosis. Here the aim is an R0 resection. In a publication by our department in BGS 2005, it has been shown on this Kaplan-Meier curve that very long period of disease-free survival can be achieved with curative surgery. However, it has also been shown that when we perform debulking for a very locally advanced disease, we don't achieve better disease-free survival than with those patients who undergo medical treatment alone after 10 years. Therefore, the expert consensus of the World Health Organization suggested to indicate surgery for stages P1 and P2, and then lesions that have a higher stage should be discussed case by case. Here it is an example of a located alveolar echinococcosis in the left liver, where we could perform a bisegmentectomy. When this is not possible because there is a hilar involvement or the complete liver is diseased or there are some complications related to the vessels like a Budd-Chiari syndrome, we have to consider liver transplantation. The 5-year survival of transplantation is 71%, with a 5-year recurrence-free survival estimated at 58%. The survival has been reported to range between 0 and 11 years. When we consider liver transplantation for echinococcosis, we have to administer albendazole therapy pre- and postoperatively. We have to meticulously evaluate if there are extrahepatic lesions, and we have to adapt the immunosuppressive regimen, keep it to a minimum to avoid the recurrence of the disease. I would like to present a case performed in our institution a couple of years ago, where a 25-year-old female patient presented with an unresectable Echinococcus alveolaris lesion of the liver, which invaded the suprahepatic vena cava and the right atrium. This short video shows the operation that has been performed. You can see the liver with the Echinococcus lesion invading the right atrium. The patient was put on extracorporeal circulation, and the hepatectomy was performed together with part of the heart. Then the patient underwent living donor liver transplantation. Here you can see the pathology of the specimen, including a part of the heart, with the presence of echinococcosis in the liver. Both the donor and the recipient recovered perfectly after this intervention and reported their happiness in a local newspaper. I'd like to talk also about future challenges in echinococcosis. First, I would like to emphasize the role of prevention, which is very important to decrease the overall number of cases. For this, we need safe animal slaughtering conditions around the world, dosing dogs with praziquantel, vaccination of sheep and dogs, and there are some new molecular methods to detect Echinococcus species in environmental sample, which can help to identify high-risk areas. On the side of the treatment, there are efforts to develop new drugs, the so-called mitogen-activated protein kinase inhibitors and tyrosine kinase inhibitors, also new drugs of immunomodulation against the laminated layer of the Echinococcosis. And last year, a paper from China reported a very challenging procedure, an ex vivo liver resection and retransplantation of the liver to the patient. So I'd like to sum up my talk. I think it's very important to know that echinococcosis is a zoonosis transmitted by fox and dogs. Cystic echinococcosis and alveolar echinococcosis are two different diseases with different behavior. The cystic echinococcosis diagnosis is based on ultrasound, and here we favorize pericystectomy together with albendazole. In contrast to the alveolar echinococcosis, where the classification is a so-called PNM classification using ultrasound, CT, sometimes PET scan, and the aim is R0 resection with or without liver transplantation and albendazole therapy. I would like to thank you for your attention. I'm looking forward to take questions.
Daniel, thank you very much for this presentation. Very well done, comprehensive, and not an easy topic. And I think one reason you do it so well is that indeed here we have experience with both of these diseases. The alveolaris, we have this disease in Switzerland, as you have shown. The hydatid cysts, or that we see with your number, usually they come from people coming from Turkey or other places around the Mediterranean that we have here. I think the main message for your presentation, and we can see, this disease belongs to specialized center. The alveolaris is probably one of the most difficult liver surgery you can imagine, and you have shown some example, and the cystic could be relatively simple, but you can do a lot of things during surgery that can generate problems. In the world, in Turkey or in Egypt, when they have a lot of hydatid cysts, they mostly treat by punction because it's very expensive to do, etc. So there's a number of publications to do this for percutaneous punction, so there is not even surgery. Here we do differently. I think our two main contribution in this field from this center, one you showed, the other one you did not, is the pericystectomy with the hydrojet. We developed that many years ago, so we go with this device, and maybe you do not have the picture here, but that's our routine first approach here when we can. We go with the hydrojet with a pressure of 30 to 50, we go around the cyst. Until today, we never perforate a cyst, and we take in total just the cyst without any liver with it. This is our preferred technique. The other contribution you show here, and that was a study that we did with Professor Mühlhaupt here and Dr. Kadri when she was here, is basically to show not only the alveolar look like cholangiocarcinoma, it's like a perihilar cholangiocarcinoma in terms of surgery. It's even worse because the spread of this goes very often extra-hepatic, which makes the situation complicated. You show this liver transplant that we did, but it also behaves like tumors. If you do only debulking, which sometimes is a temptation because it's so complicated, you probably don't offer much versus simple therapy. Maybe it's a question that I can ask Beat to answer. Is there any role for debulking in alveolaris, or should we go only when we think we can go for a resection. We have done also one autotransplant. You show at the end here, there's a number of studies from China, particularly when they have a lot of this disease, alveolaris in Tibet. I don't know which animal, it seems that's another animal in Tibet, I did not know, but it's very endemic in Tibet, and they often go and do this surgery, and they became expert. They published the result, very absolutely outstanding, of ex vivo transplantation. You take it out, which is a very challenging procedure. We did one here, there's been other series from France. But basically, I mean, my question is also to Beat, if we do, and this is expensive, if we do for alveolaris now curative resection, we always give adjuvant therapy with albendazole, and I wonder if we really have R0 resection, when I see the cost of that, if there is really strong data, any data that suggests to tell us that we do use adjuvant therapy for this patient. And my other question also to use your expert, in Zurich we see fox everywhere now, particularly with this COVID time. They come everywhere. I showed a picture, one even of these fox enter the hospital. Are they dangerous? Are they treated? Are they today, can we get that in the street in Zurich to be contaminated for Echinococcus?
I mean, the second question first, yes, of course, they're dangerous. I mean, they're contaminated, 40% in Switzerland or in the Zurich area, and you can get infected. The infection rate is probably low. We don't know this for sure, but the infection rate is probably low. Exposure is high and infection is low, but it's possible, yes. And that's why you should not feed your foxes in urban areas. I mean, that's one of the main reasons. I mean, they have tried. It's possible to decontaminate foxes. It's very expensive. You have to do it long term, and the feeling is that the cost-benefit ratio is not sufficiently high, and that's why they don't do it. But it's possible, and it's also so that the reservoir of foxes in cities is a lot smaller than outside, because the food per square meter is a lot higher in cities, so they can live on smaller places. Yeah. And the second one regarding debulking, I mean, I think exceptionally this might be a case, but otherwise I don't see a reason for debulking. And then the 2-year follow-up is, I mean, there has never been done a randomized trial that compared 1 year to 2 years. I mean, there are certainly historical case reports, and this is our series, but it's a little bit difficult to compare maybe also surgical techniques in the past to surgical techniques today. But in the past, I mean, it has been reported that after R0 resection without adjuvant treatment, there have been recurrences. Recurrences can occur up to 10 years, and I think that's one of the problem with the Chinese studies. Chinese studies, they don't have long-term follow-up. I mean, they show very nice short-term surgical results, but they don't show any long-term follow-up, and that's why I'm skeptical about the Chinese results.
Like many treatment in surgery, there's bias of what you can do. And if we were taking the old people with the edatid cyst now, most are probably treated just by percutaneous punction. They inject sometimes alcohol, which can be very dangerous. I think we don't do that here because of the risk of biliary lesions, so they use other things. Do we have any data? Because we receive a number of these large series from Egypt, for example. Here we never do that. As far as I know, we go with the pericystectomy. We may even do minimally invasive. We do open still today because of the risk of rupture, but I may imagine soon that we will do that also minimally invasive. There is any serious data that suggests that the percutan is effective?
I'm not so familiar with the data on cystic echinococcosis, but I think there has been a randomized trial done, published even in the New England Journal maybe 20 years ago from somewhere in the Arabic Peninsula. And I mean, obviously in Turkey they do a lot. In Turkey they believe in pair. But in Turkey, I'm not aware of a randomized control trial. But I think in the New England Journal, there has been one trial maybe 20 years ago that looked at that. Also there, I think it depends on selection. I mean, on cyst size. I mean, the larger the cyst, the higher the risk of having biliary connections. And then obviously the pair has its side effects regarding biliary sclerosing cholangitis.
Okay. Thank you.